Hi there. Welcome to our program. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma, and I'm glad to have you join me today as we discuss an interesting case and diagnosis in bone and soft tissue pathology. So let's begin with the case. This comes from some of my consultation work, but also includes some cases drawn from the library of the Digital Anatomic Pathology Academy, which is a joint venture with Path Presenter and the Digital Pathology Association, membership in which is, of course, complementary to those in training and to those in the developing world. So the patient is a 49-year-old man who has had a history of kind of chronic ongoing arm pain and more recently has experienced loss of wrist function. But as we look at the X-ray in this next image, I think you'll see that we're not getting the entire story, because it appears that he's probably had some surgery to resect or reconstruct a portion here of his ulna. With this rounded edge here, it has the appearance of something that has either not ever formed or potentially has been resected and has had some time to reform. We don't see too much of a mass lesion here in this area where there's relatively smooth contours of the soft tissue. But this is where the tissue has come from. And the sample that I received in consultation was of a spindle cell tumor. There was very little accompanying history, and I showed the X-rays to my radiology colleagues and who wondered about some sort of prior resection, or possibly whether there was a metabolic disease, hyperparathyroidism, leading to some degree of osteopenia and chronic bone loss in this setting. So what do we see under the microscope? Let's take a look together at this first slide as it loads. A little bit challenging to load because it's quite a large sample. Now I have a couple of sections from this tumor, and as you can see at low power, it's kind of intermediate cellularity. We have some sort of hyaline or pinkish areas as well as more cellular areas. And if you are sharp, you may have picked up that it looks like we've got maybe a couple areas of bone or calcification here in this tissue. So let's look first here at the less cellular areas and see what this is. Is this osteoid? Well, in fact, it does appear to have somewhat of an osteoid-like appearance with occasional cells within the matrix. And we could confirm this, though not using digital slides, by using polarized light microscopy, which should show you the parallel collagenous bands that are more typically associated with osteoid formation and help to distinguish this from regular collagen or from fibrin. As we look, however, at this a little bit more fully, I think even though there are occasional nuclei in here, for the most part, they don't look quite the same as the nuclei in the surrounding tissues. So that's one thing that made me wonder if this bone or osteoid formation was truly coming out of the tumor. Here's another one. Here's one that's a little bit maybe calcified, not very cellular. And then here are some others up here, as you see a little bit of calcification. We note that they're mostly sort of spindle-shaped cells, slightly rounded nuclei, a few nucleoli, nothing in the way of marked pleomorphism, maybe a few giant cells, as we see here, maybe a few inflammatory cells, but no atypical mitoses, not any significant atypia. Take a look at another slide, a little bit different view of this tumor, and let us focus in on what we see with this one. The patient age group is a little bit significant. It's an adult. This is not a common age period for osteosarcoma, of course, and the location, of course, we don't have a native X-ray to give us that appearance. Here's a little bit more of this appearance, and here again, I think you can see the cellularity here, the atypia in the areas which may be osteoid is very minimal or non-existent. Here we see, again, a bit more of this more kind of reactive type of bone formation. And again, I think polarized light exam would be very helpful and instructive in this situation. Here's maybe a little bit of giant cell or pleomorphism to the lesion. And here a few of the vascular structures. Here you see slightly ectatic vessels. And again, here, some of this sort of ectatic vessel type appearance to this. Well, given this microscopic appearance, I think our differential would include osteosarcoma, kind of a low-grade type of osteosarcoma, and other spindle cell tumors. So with that in mind, my colleagues did some immunohistochemistries and provided the results that they had for this. So they did SATB2, which they reported as positive, SMA, which also was positive, and then some somewhat non-specific stains, CD68, and maybe a little bit of CD163. I don't think these are truly indicative of histiocytic differentiation per se. There was negative P53, P63, and Desmond myogenic markers were negative. Let's take a look at some of these. Here is the SATB2 stain. And as we can see, the positive cells are fairly diffusely arranged in this. Some of the cells within the matrix do stain with this as well. So they may be related cells, and that may suggest the possibility of osteosarcoma. However, the muscle actin stain, here's again the SATB2, a little higher magnification, showing this rare positive cell in the matrix over here, maybe a little bit of fat here and there, and then the positive spindle cells. The SMA was positive, however, and this is the more weakly positive area. There was quite some areas of quite strong positivity within the cytoplasm of these many of these cells. Here we can see a small vessel with striking positivity, but even the stromal cells here are definitely positive in this area. However, myogenic markers were entirely negative, Desmond, myogenin, and so forth. Well, that struck me as a somewhat unusual possibility, so I decided to do a little bit of research, and I plugged those antibody results into ImmunoQuery. As you know, you can build diagnostic panels with ImmunoQuery, looking either at differential diagnostic considerations to guide you in selecting immunostains, or when you have somewhat puzzling immunostains, you can enter the results or the antibodies you're concerned about and see what the answers are. Well, so what's positive with SATB2 and smooth muscle actin? Well, relatively few things. Intimal sarcoma, which this obviously is not, it doesn't have the presentation or the histology of intimal sarcoma. But of course, not everything is 100%. And as we look at those that are SATB positive and smooth muscle maybe positive in some cases, we get a fairly small list. Obviously, this is not sinonasal carcinoma or neuroblastoma, but a small cell osteosarcoma in the differential with a rare 6% of tumors being positive with SMA, or this diagnosis of the phosphaturic mesenchymal tumor having 25% of its cases staining with smooth muscle active, and a reasonable number of cases processed to develop that. Looking here at the other considerations where, SABTB2 would be the outlier, we don't see anything here that looks to be within our histologic differential based on the H&E. So given these findings, and as we look down here further, we can see, okay, angiosarcomas, occasional cases are SATB2 positive and smooth muscle actin positive, but this, again, does not look like an angiosarcoma or a mesenchymal chondrosarcoma. So I think our clear differential here is between osteogenic sarcoma of small cell type or a mixed connective tissue type of phosphaturic mesenchymal tumor. So with that consideration, what is phosphaturic mesenchymal tumor? Well, this classically is a tumor of middle age and the extremities. Occasionally intraosseous, but rarely, and is associated with long-standing vitamin D resistant osteomalacia, osteogenic wasting, such as this patient has, and some degree of pain. The microscopic appearance can be quite variable, and although typically described as having some elements of chondromyxoid matrix, these can be quite spotty. And in addition, it's mostly spindle cells, rare giant cells, maybe some fat, and some ectatic thin-walled HPC-like vessels. Importantly, this has a fusion gene that's either fusing FGF1 or FGF23 with a fusion partner. And once it's been resected, the osteomalacia typically is completely resolved and you'll have relatively normal structures. Now, it would have been helpful in our case had there been, urine phosphates or other chemical measurements looking to see if this patient had evidence of bony wasting and so forth. But clearly we have radiographic evidence of some degree of chondromalacia, or excuse me, of osteopenia developing that may reflect some degree of phosphaturia. So based on these findings, the more appropriate age group, location, lack of clear other findings indicating osteosarcoma, despite the fact that we have some degree of osseous type matrix, I think this fits better into the category of phosphaturic mesenchymal tumor. Now, just as a case example, what does this look like in other settings? Well, here's a representative slide which you can view using the QR code taken from the DAPA files. And that slide looks like this. And this is a rare case where we do have an intraosseous tumor. And the morphology is somewhat similar, not a dead ringer, but certainly similar enough, fairly monotonous, appearing vaguely spindle-shaped or epithelioid type cells, some spaces, associated vessels, and very low-grade appearing. It does have some areas of hyaline change, which, as you can see here, begin to resemble some of that osteoid-like matrix that we saw in our case. And you see here again. And also we have some elements of ectatic HPC-like vessels in a few areas. Here's one here, and here's one here that's sort of involving these cystic spaces, which are a bit more prominent. But notice here that we have very little in the way of the chondroid matrix other than this sort of microcystic pattern here. So this is a challenging diagnosis. It's not something we see every day, and I believe that we've made the correct diagnosis here. Of course, the proof of the pudding here might be further chemical investigation of the patient's studies previously, or assessment of what's happened to their phosphaturia now that the lesion has been resected. If we had available the molecular testing to look for the FGF1 or FGF23 fusion gene partner, we could do that testing as well. Well, I hope that this has been helpful to you, or at least spurred some thoughts and thinking. If you don't agree with me, you can certainly express that and put your comments in the diagnosis. Or if you have other thoughts on this case or this process, please feel free to reach out to me. We welcome your comments and hope that our presentations will be of use to you in your practice, and we look forward to being with you again in the near future. So until next time, thanks so much for joining me.